happening there. Please go ahead. Hi, Pedro. I'm going to give the floor to Dr. Leah to talk about this. Very well. That's wonderful. Go ahead, Leah. Good morning. Based on the experience of our Merida workshop, we decided the workshop in that city with all the health centers, there are 13. And we worked with them so that each health center were to measure its maturity index. And well, we started with local data. Each center worked with their own data, I'm sorry, to establish a baseline of numbers and know what is the gap that had to be overcome. So using the maturity index for each center and the quality committees has already been created within each health center. These committees had the director, the epidemiologist, the social worker, epidemiology, quality, because we have a quality manager, and we also included nurse and whoever is responsible for information or data. A platform was created, each center uploaded their data. Improvement plan was developed for each center for a 3-month period, and based on using their baseline, they showed in which areas they were going to work. They were going to be able to move in their quality index. Simultaneously, we worked with the pharmacy and the filing section to establish the patient flow so that once a person got to the unit, if they had high blood pressure, we wanted to make sure that there were no problems in access. And with pharmacy also, so that used on existing mechanisms for the delivery of medicines to people, make sure that the clinical pathway was complied with. If it is a person with cardiovascular risk, that the medications were prescribed to them. And we needed to see the average consumption or use so that they were able to procure the medicine in a timely manner. And now we are working with the institute and we'll start coordinating with the Social Security institution, because the Ministry of all of this has been now derived over to this new institution. It's impressive how you've achieved it. But there is something here that needs to be repeated by others. We're going to share this presentation with all of you, obviously, when we end the webinar. But what is it that we want to do? We want to strengthen the health center's capacity. It can be at the subnational, national level, but this has to come from the health center because they are the ones who can manage things to achieve change. And that, I think, is the chief resource. In other words, strengthen the primary health care. And if where management is done, there is no data, well, then you can't share a program with them. It's as simple as that. It cannot be done without having a baseline and knowing what's happening. So it's very encouraging to know this is happening in Mexico. We know that there are more than 60 million users in that institute in Mexico. We heard this from Vivian a couple of days ago. It's 40-some million. The ordinary LINS has a coverage of 47% of the population. That's about 60 million. And the INS well-being is now going to take over the delivery of services and all the healthcare centers that were part of the Ministry of Health. And that includes some 12,000 establishments of the primary care and the rest of the population. Mexico has about 130 million inhabitants. But everything is interlinked. So let us see the strategies. You have seen that, and we're going to see the slide of how we evaluate indicators. Each country, try and see where you're at. You're going to have a preliminary status. It doesn't matter what it is. It doesn't have to be accurate right now. We just want you to start looking at the challenges you face. Through strategy 5, I need to say how much my country would accumulate. And don't forget what I mentioned earlier. We're not in a society of mutual praise, or mutual complacency. No, we're trying to see how to improve what we're doing. Because if we continue saying that we're doing everything wonderfully, but mortality increases, then either we're crazy or we don't know what we're doing, one or the other. And for that, it's necessary to do things in a different way and to be accountable. The government, the state, the country, the citizens of a country provide the resources, they pay taxes, they define their laws in order to have better health care. But then we need to create better care that is based on indicators. We need to be responsive, to be accountable about the effect that we're having with our health policy, and it shouldn't just be rhetoric. HEARTS is a multi-component program. It's a quality program. It is a quality to improve clinical performance. We need to have conditions when we look at this, to have validated gauges, effective levels, institutionalized clinical pathway. And above that, we say,
optimize the quality of care. Optimize the quality of care. How can we say the poor? We can't say this is medicine for the poor to improve the quality of care for them. But actually, when we use those kinds of arguments, elitist arguments, the clinical the treatment is in the hands of the primary healthcare people who have great experience, and we don't do healthcare at the primary healthcare level, we're not going to be successful because they are the key to success. Pedro would like to say something very quickly. All of the health centers have validated equipment. We started with the donation given to us by PAHO, but Mexico also has a program of the government called the Clinic is Ours, Belongs to Us, where we give the budget to local health committees. So we meet with each of the local health committees. We introduce HEARTS to them. We explain it to them. We tell them